Achilles tendon ruptures. You may have had one, you know someone who's had one, or you might have seen an athlete on TV get one. We're going to talk about what is an Achilles tendon, how does it rupture, and how do you treat it?
Welcome to Talking with Docs. I'm Dr. Brad Wiener.
And I'm Dr. Paul Zalzal.
I'm Dr. Danny Aurora. Thanks for having me, guys.
Awesome to have you back. Danny's a foot and ankle surgeon. He's here to talk all about Achilles tendon ruptures. As someone who lives in the GTA, the most famous Achilles tendon rupture is probably Kevin Durant that helped secure the Raptors championship back in 2019.
Kevin Durant for the Raptors?
No, Kevin Durant was on the Golden State Warriors,
Oh,
the opponents
yes.
that made him
Okay.
not be able to play and helped secure the victory for the Raptors.
That's true. That's true.
Okay, so there you go. So Achilles tendon rupture, let's start at the very beginning. What is it?
So the Achilles tendon is basically a large tendon in the back of the heel and the ankle. It's the strongest tendon in the body.
Okay.
It's where your calf muscles, there's the gastrocnemius, you have both sides, two heads, the medial and lateral, so the outside and inside part of the calf with the soleus muscle, and they converge at the bottom of the back of the heel and form the Achilles tendon. So it's a pretty long tendon at the back, and it provides what we call plantar flexion, or the push off of your foot and the ankle.
And we talked about this before. A tendon connects a muscle to a bone, whereas a ligament connects a bone to a bone. So
And if you're wondering why it's called the Achilles tendon,
okay,
stick
a little
around
history.
till the end.
Okay, I like
I'll
it.
give it to you at the end.
Okay,
fact.
so who gets this kind of injury?
Yeah, so I mean, classically, you hear about the weakened warriors, people in their middle ages, 40 plus, that could get it. People try to do some sports, try to be a little bit more active. However, I could tell you anecdotally, and also we're starting to see that in professional athletes a lot. We see it in younger patients. Just recently, I did an Achilles tendon repair in a 20-year-old varsity football player. So
Wow.
It's happening much younger, and it can happen at all ages.
Okay.
And so what kind of sports or activities predispose you to rupturing your
Yeah,
Achilles
so it's a
tendon?
good question. So I think the big thing is people are doing some type of push off. So the Achilles tendon, like I said before, is the major plantar flexor. So it provides that push off. So you usually see it in sports like tennis, soccer, football, basketball, and most recently the big spike sport, like the spike in incidence.
Don't say pickleball.
It's pickleball.
Pickleball.
Pickleball's our new best friend.
Okay.
Right, okay.
Keeps us
So
going.
that Achilles tendon makes you point your toe down. So any activity where you're trying to push off by pointing your toe down to accelerate can cause it. And now pickleball, of course, to get that wiffle ball, you don't want to lose that point.
Okay.
Sacrifice your tendon.
So now we know the sports. Are there any medical risk factors, Danny? So predisposing factors in patients that say this means you're at slightly higher risk of getting
Yeah,
trauma.
so there's thought that if someone has underlying Achilles tendinosis or chronic tendinopathy or a previous injury, you could be prone to a re-tear or actually a true tear. People who are on quinolones, which is a type of medication. People who get steroid injections in the back could be predisposed to a tendon rupture. So I always say do not get a cortisone injection in the back of the heel or in the Achilles. We do see that sometimes, unfortunate for patients because they get that tendon rupture as a result.
Right.
There's some patients who have risk factors like obesity, diabetics. So that's kind of the
You
population.
mentioned cortisone injections in the back. We're talking about in the back of the heel, not
Correct.
in your back. Getting a cortisone injection in your back for chronic back pain does not predispose you to an Achilles tendon rupture.
The
Absolutely.
last one that I would say, and you can tell me if this is true if you've seen this, what about anabolic steroids? Typically, these people are at risk of tendon ruptures, triceps and the quads, but what about the Achilles?
Yeah, it can happen as well, 100%. That's part of, when we do our history taking with the patient or athlete, we try to figure out, why this could have happened, if there's anything predisposing to them to have it, if it's an unusual presentation.
Yeah.
That could also
That's
factor
why
in.
I stopped using them.
Yeah, and your scrubs weren't fitting anymore.
That's
That's
right.
why you're getting too jacked.
All right, so give us the symptoms. How do I know I've ruptured my Achilles tendon?
Yeah, so usually the classic presentation is someone is doing some type of sport or activity where they're running and they feel a pop or some type of sudden sharp pain in the back of the heel. They usually look back and say, who hit me or clipped me from behind?
That's right.
And no one's there. And they usually have some instant pain in the back. Sometimes they have difficulty actually weight bearing or walking because they have that floppy foot. They sometimes have a lot of sharp pain in the calf area as well.
I've seen one happen acutely.
Okay.
We were playing soccer, pickup soccer with some parents and some kids, and one adult was just lunging like crazy lunge and just went down.
Yeah.
And examining it right away was kind of cool because usually we see them a day after, a couple days after. To see it minutes after it happened.
You could sometimes actually hear it
Yeah,
when it's
hear
like
it pop.
really, really forceful one. You can actually, number one, you could see it. You see them on sometimes on replays when you see it in like the pro athletes.
Yep.
You actually see it when the tendon lets go, when they really slow down the video footage. But definitely, it could be quite apparent, and the patient or the athlete know right away something's wrong.
Something's wrong. Felt like someone hit me in the back of the leg, even though no one was around.
Yeah.
Okay, so you got some pain, some swelling, difficulty weight bearing. What do you do as a patient or as a observer or bystander? What does that patient need to do?
Yeah, so I think right away you need to be, splinted or put into some type of boot and then brought to the hospital to get treated and to at least get that diagnosis going.
Okay.
The key thing after we diagnose or there's a clinical suspicion of an Achilles rupture is to really get them in that plantar flexion splint. So essentially we want to put the patient with their toes pointing downwards and splinting them like that, whether it is to then get your imaging after or for the referral to the orthopedic surgeon. In our center here, like to get them seen right away. So I've basically said any Achilles tendon ruptures could go right into my next clinic because I like to get it early because then we can have the discussion about what to do next.
Right. Okay, so when you physically see them, as say you get called, the emergency doctor
Yeah.
says, yeah, I'm pretty sure they've got Achilles tendon rupture. What do you've done history. What are you seeing on physical examination? What kind of special tests are you ordering?
Yeah, so again, like I said, the first thing that I can't stress enough is getting the immediate splinting and plantar flexion. I cannot stress that enough because a lot of times patients are either just put into a neutral boot and they're just walking on it, and that really can negatively impact their outcome after. And that's the most important thing, to get that tendon at position. And then whatever direction we go, when the patients come to me, that's the most important factor that helps them with their prognosis.
Okay, so you want to, if this happens to you, you want to get splinted with your toe pointed down as much as possible, like a ballerina.
Yeah.
You really want your toe pointed down.
And it doesn't matter how, if they don't even have plaster, I think anything to just keep the toes pointing down, I think that's better. And then the referral to the orthopedic surgeon is probably
Couple
what you want.
sticks in the woods. I mean, anything to keep it
Whatever
down.
it takes.
And the reason is because when your tendon ruptures, imagine two ends of like a rope or a mop. They're inside of a tendon sheath, and we want them, if your toes are down, they're closer together. So
Correct.
already your body's starting to heal them, rather than if your toes are straight up, those edges come far apart, and it's just harder for them to be in contact.
And you lose that tension, right? So if it's already where the tendons are reapproximated together, and then again, like I said, you could then determine whether you're gonna go whatever avenue, which we'll discuss in a bit.
And what's that special test you do on physical examination?
Yeah, so on physical exam, I have a couple things that I do. Number one, we have the patient lie down on their stomach. We take a look. You could definitely inspect both Achilles tendons to compare.
Yep.
There's usually a quite apparent difference between the intact tendon and the torn tendon. It's usually swollen. Sometimes patients will have pain in the calf. You could see an actual gap or difference in terms of the integrity of the tendon. The big thing is the position of the toes. You have that loss of plantar flexion position of the toes. So if you have the patient lying down flat, the intact side will have the toes pointed in an angle, usually about 45 degrees, and the one that's actually torn, the foot is completely down to neutral, and that's more apparent when you actually bend their knees up, and you can see the side-to-side difference. So one foot's up, pointing up to the ceiling, like this, and then the other one's gonna be neutral down like that, and that usually is quite indicative. So that would be step one. Step two, you want to do what's called the Thompson test, and that's usually, there's different variabilities, whether you put the leg down and you squeeze the calf and you see if the foot is flickering. If you get that plantar flexion, I like to actually bend the knee up and I see that difference and I compare it to the other side, and that's pretty apparent as well. And then the other thing, you lose that recoil. So when you bend down on the foot, an intact Achilles usually has the recoil back of the toes pointing up to the ceiling. When you have a torn Achilles tendon, that there's not that flip back or that recoil that we see.
And you can also feel it. You can run your finger along the tendon on one side, and the
gap
other
is
side,
definitely,
you feel that gap.
Yeah, 100%.
Okay,
So it's a
so-
very clinical diagnosis. Like when we see it, sometimes patients are referred to us with imaging. We don't always necessarily need it. It's usually pretty clinically, apparent, and we could definitely make that diagnosis.
It's a clinical diagnosis. You were about to
Yes,
ask.
I think that's a great thing. So you're confident that it's torn. Where is the role for ultrasound and or MRI for you?
Yeah, so I think when it's not clearly or fully torn, if let's say in a case where you still have some of the findings but not all the findings, If the pain is higher up, you can't really palpate or really feel that gap. If the pain is more proximal, meaning higher up in the calf.
Like a torn calf maybe instead.
It could be a calf strain or something like that. Those are different, and the treatments are a little bit different for those as well. So that's where we get a role for musculoskeletal ultrasound or potentially even an MRI.
Okay.
All right, so it's a clinical diagnosis. If you have all those signs and your doctor finds all those signs, then you know that the doctor will know that it's rupture. But if there's any question, then an ultrasound or an MRI can be helpful. All right, so we have the diagnosis. We have the history. It was a sporting event, pickleball, pop, felt like someone hit me in the back of the leg. I couldn't walk after. It's very difficult to walk after you've ruptured your Achilles tendon. You go see the doc and you have all these signs, and yes, you have the diagnosis of Achilles tendon rupture. What do we do now?
Yeah, so it's very, this is important now, and this is a case per case. I think the big thing is not Achilles tendon ruptures, number one, need surgery. Not every Achilles tendon rupture has to go non-surgical, and it's really a case per case, long discussion with the patient. You need to identify the patient's risk factors, you need to identify the patient's activity level, what their goals are. Number two, if they were appropriately splinted initially. Number three, the location of the tear makes a big difference, because if it's a high calf strain or a tear near where the muscle meets the tendon, those don't usually bode well to surgical repair. Those would be more ones that we would want to treat without an operation. Right. And again, then you go over the risks and benefits of surgery versus no surgery, which there's tons of literature out there, and it's just a matter of narrowing down the big salient points of that.
Okay, so it's operative and non-operative. And the key here, one of the key reasons to get splinted with your toe pointed down as soon as possible, because if you get splinted appropriately, then both options are still available to you. Right. If you spent 2 weeks or 3 weeks in a neutral position, not with your toe pointed down right after the injury, then you said almost goodbye to the non-operative option and you bought a surgical option, because it won't heal as well non-operatively if you didn't get splinted appropriately. That's why we spent so much time emphasizing the importance of that splinting with your toe pointed down.
Yeah. So the early recognition of the injury, the early splinting right away, and then the referral to the surgeon, and then the decision can then be made with the patient and the surgeon to determine what's best for the patient.
Okay.
Okay, so be sure to leave a comment if you have a torn Achilles, if you had some type of treatment, if you're debating it, leave a comment. It's going to help other viewers. So let's start with the non-operative side.
Yeah.
So you've come to a decision with what the patient wants, needs, and your thoughts on their injury. You said, okay, we're decided we're going to go with non-operative treatment. What does that look like for people?
So just in terms of the differences, I think this is the big thing, because everyone, if you look at some of the recent, there's old literature and there's new literature. The big differences between non-surgical and surgical are, number one, with the non-surgical arm, you avoid all surgical risk, which is pretty, we understand that, right? If you don't have surgery, you don't have surgical risk, but that's the big thing. You do not have those surgical risks that come with it, like wound complications, infection, all that stuff.
We always talk about, anytime we do surgery, there's always risk of things like heart attack, stroke, death, blood clot, infection, pneumonia, wound complications, because the Achilles tendon is so superficial. There's not a lot of your body covering the end of the tendon, the back of the tendon, so the risk of some sort of infection is present.
And the blood supply is a little bit poor in that back area as well. So, so definitely that's the big pro to having a non-surgical way of managing it. Now, the differences between surgical and non-surgical, number one would be the chance of re-rupture. That's the highly quoted findings in the evidence in the literature. There's tons of recent meta-analyses, randomized controlled trials. The jury's still out, right? Because you can still technically be treated well with either option. Yeah. But one would think, if you had to really summarize the literature, it's about a 3 to 5% chance, that's what I quote my patients, of re-rupture with surgery, and about a 10 to 12% chance of re-rupture without surgery. So still pretty low, however, it's almost double the risk. Yeah. Some studies say it's almost 10 times the risk of re-rupture without an operation.
Right.
Wow. Okay, so re-rupture.
So that's number one. And then the number two thing would be the plantar flexion strength. There's some literature out there to say that if you have surgery, you would gain or at least have more plantar flexion strength, or that push-off strength, compared to those who do not have surgery. And the third big thing is, you could sometimes accelerate the rehab a little bit faster and the recovery is a little bit quicker with an operation compared to without an operation. But again, more apparent and more obvious in someone who's like a pro athlete, someone who has to get to an active job or lifestyle. So again, those are the types of discussions we have with the patient to see, which arm are they going to go to? Are they going to go surgical or are they going to go non-surgical?
Okay, so that recovery, is that a quick 2-weeker, 3-weeker, or is that a
Yeah.
prolonged recovery?
It's a prolonged recovery. So even with, so if we go non-surgical, you're looking at a minimum of 6 months before you're, back to potentially trying to do some sports. And sometimes it could be even longer, even up to 9 months in some patients. If you go surgically, you're looking at a minimum of 6 months. But again, if you're a pro athlete, they usually take the full year off. Case in point, Kevin Durant took the whole next season off. Again, because you just want to be 100% to go back to doing that elite level activity.
Didn't Durant come back a little soon? Like
He
had
did.
an injury,
Yeah.
came back a little bit soon.
And then completed his rupture. And
Yeah.
I think what's interesting, if you look at elite athletes like him, even with surgery, unfortunately, because of that kind of narrow margin of being great, and like good versus great, a lot of them, any of the professional, even Kobe Bryant, they show that their performance after they come back, it just never quite gets back, which is understandable.
Yeah.
Even with great surgery and full strength and full function, they never quite get back to normal.
Yeah, that's why I never went back to the professional basketball.
That was your career killer?
Oh no, I just worried it would happen, so I took that off the table.
I think
choice.
the other side note too that I think it's hard to tease out is that like when we started practice, like Paul and I 30 years ago, like everybody got surgery, but it was a much bigger operation. So yes, we still did it all, but then there was more complications. So now then non-operative treatment got better.
Yeah.
And then now kind of surgery treatment has gotten better. So like they're kind of, it's like a little bit of a race where there's so
Yeah.
many different variables. It's even hard to tease out in some of the literature, but yeah, definitely surgery has really changed nowadays.
Yeah, so and to go over those treatment options.
Yes.
So the non-surgical way of treating it, number one is the accelerated rehab protocol. There's tons of literature out there. The key is early weight bearing in a plantar flexion type boot or splint.
When you say early, how early are we talking about?
You could technically, if caught early and
Yeah.
the patient was appropriately splinted in plantar
So
flexion,
you see them 4 days after the injury, they were appropriately splinted, now they're in your clinic.
so they could technically walk on it right away with a wedge or some type of plantar flexion boot.
Okay, got it.
So that would be early weight bearing, early range of motion within parameters. There's protocols that we have to
Yep.
do that, the physiotherapists usually, and getting really linked up with a good therapist who has actual experience with Achilles tendon ruptures and management.
Right.
That is the key to your recovery.
Okay.
But that's how we would approach it that way. And then, we have close follow-ups and we see how things progress. But you're looking at it still a good 6 months before you're getting back to any type of physical activity level.
And with that protocol, you're seeing them every couple of weeks, and you're just reducing the wedge. So say you're 30 degrees down, and then 15, and then
Correct.
neutral dorsiflexion.
Correct.
Okay.
So it is one of those gradual things where you're starting in that full plantar flexion, usually about 30 degrees plantar flexion, and then every couple of weeks you're going to take down a wedge to try to slowly lengthen the tendon, but in a controlled, protected manner.
Right. Okay.
And then the boot comes off usually around week 6 or so, and then that's where you start doing more physical activities to get the strengthening, and hopefully eventually back to some sport-specific stuff.
So at 6 weeks, they're out of the boot.
6 to 8 weeks is usually that timeline.
Okay.
Again, it's case per case, right? Some patients might be a little bit slower to actually start putting weight on it.
Right.
They might have been delayed to be seen, initially. So there's a bit of variability. It's not like a hard, it's
Yeah.
not black and white, unfortunately.
Okay.
Yeah.
Okay, and you're saying once you get yourself into a neutral position, so you're going to start the toe pointed down. Gradually, we're going to bring it up a little bit less point down, a little less point down, a little less point down. Then you're going to be in a neutral position, still in a boot for a little bit in the neutral position. But the physiotherapy that's going alongside that is what's key.
Yeah, and doing those exercises, during that time period so that the muscle is ready to then start working out of the boot. It's not going to be where you're casted for 6 weeks not doing anything. And I think that used to be
That
a
used to
way
be the way we
of
did
treating
it.
it. I
Yeah.
think that has come a long way and we've completely gone away from that.
Yeah.
Because that would delay the recovery.
Yeah, so we have definitely accelerated that. And then again, it's going to be at least 6 months before you're even considering any kind of physical activity that you might have been doing before this rupture.
Right, and you need to get clearance from your therapist or by the surgeon. You want to see that your calf muscle has gone back. That could take even sometimes a year to get that same amount of muscle girth or activation from the calf muscle compared to the other side, right? So there are certain parameters before return to actual, elite level sports or whatnot.
The one thing for me that I always look for before we talk about discharging from the clinic is, can you do a single leg toe stance?
Yeah.
If you can go up on one leg, go up on your toes on that
That's
leg.
part of the recovery for sure, and there's different times in the protocol where we try to attempt to do that. Sometimes
Yeah.
around 2 to 3 months is where we would like for them to start trying to do that. Doesn't mean
Yeah.
they're ready for sport,
Yeah.
but you need to do that before you
Yeah,
can.
I figure it's usually around the 6 month mark when I get people to be able to do that.
Yeah.
Okay, so that's non-operative.
Yep.
And then operative recovery, you talked about a little bit there.
Yeah, so surgery, and this is a big difference, right? The big thing back in the day we used to do, or the classic way, was to be big incisions, higher level wound complications, poor healing of the wound. You know, that took a long time, a lot of risk of infection, and that's where all the old literature would, you know, knock the surgery, and rightfully so. Now we're doing things a lot slicker, where the technology has improved, the incisions are really tiny. We do minimally invasive or percutaneous. There's different ways of doing it, or mini open. You know, so there's a way that I like to do it, is a little tiny transverse incision right at the tear site. It's usually about 2 or 3 centimeters. We use a percutaneous jig that goes up the tendon. We weave some sutures. The sutures get brought back down through that little incision. And then there's different ways of then repairing it. Sometimes you could do what's called a knotless repair, where the sutures get threaded down and then docked into the heel with 2 bioabsorbable anchors.
Right, which used to be a problem, right? Big knots, because it was really strong suture is a problem.
And sometimes people do the same thing where they run the jig on the bottom part and then they tie the sutures there. But I prefer the knotless, where there's not all the suture material at the tear site. And again, the goal is to reapproximate the tendons so it meshes down together, and you get a nice, strong repair.
Okay. So when you have that operation, so it's typically a regional anesthetic, I'm assuming. People are often going home the same day, or most commonly going home the same day.
So usually it's a general anesthetic for the most part.
Okay.
Patients are asleep because they're going to be on
Oh,
their
they're
stomach.
prone, yeah, sorry.
Surgery is really quick. Usually takes about, you know, could be 30 minutes, sometimes 45 minutes, but definitely under an hour.
Yep.
It's pretty quick. It's a day surgery, go home the same day.
Yep.
I usually splint them after the surgery to be non-weight bearing, just to protect everything for, you know, 10 to 14 days.
Yep.
And then we get them into the boot and do that accelerated protocol.
And then is the protocol quite comparable then to the non-op protocol, just a little bit accelerated?
Very similar, but you could definitely see where you could push the patient, because you have a little bit more confidence in that repair versus someone who's non-surgical, where we're just making sure that things are strong enough.
Sure.
Yeah.
All right.
It's awesome.
There it is. So Achilles, named after Achilles, the Greek mythologic character, whose mom dipped him in the river Styx to make him invulnerable, but she held him by the heels. So that part didn't get protected. So the rest of him,
his Achilles heel.
so his Achilles heel, and that's how he died in the Trojan War, so the myth goes, because he got an arrow, would you believe, right into the heel.
Brad Pitt, right? It's not Brad Pitt.
Where's that? Played by Brad Pitt?
How would that kill you though?
Achilles? Well, you can't run away from the tigers and the lions.
Yeah,
okay.
We're chasing you back in
Sitting
the
duck.
day.
It
Right?
didn't really kill
My
him, but yeah,
Achilles,
something
Achilles,
else killed him.
Achilles.
Led to his demise.
Yeah,
Yes.
right?
Just to sign up for the post-op, what are your thoughts on anticoagulation for the Achilles tendon
Yeah,
ruptures? Because it's hard to
100%.
know what to do with.
So for me, whether you're going surgical or non-surgical, everyone gets some type of anticoagulation prevention or prophylaxis.
So from aspirin to fragment
So
as
pretty
well.
much everyone gets a baby aspirin
Okay.
for a minimum of 4 weeks,
Yep.
sometimes up to 6 weeks.
Sure, and-
surgery or even no surgery. I
And-
think it's very important.
Anticoagulation is tricky, right? So you're always trying to weigh the risk of bleeding versus the risk of clotting. So that's a decision you make with your doctor, but often it is quite safe. So yeah, I agree that we can't.
I've seen blood clots in healthy patients who have a non-surgical Achilles treated, and then also post-op even after surgery, unfortunately.
Yeah. Okay. That's
That's
awesome
pretty
summary.
much summary. Good,
Okay.
thanks a lot, Dr. Aurora.
Thanks for having me, guys. Always a pleasure being here.
Now you know. Please leave a comment. If you like this video, please like it. Subscribe to our channel.
And remember, you are in charge of your own health.
See you next time.